Hello everybody, my name is Carly Bands and today I will be presenting over Case B. Case B gives this patient Mr. B, a 78-year-old male who is presenting with fatigue, dizziness, and shortness of breath on exertion. His vital signs are a blood pressure of 110/70, a heart rate of 92, and a respiration rate of 18. His physical exam shows pale conjunctiva, a systolic murmur, and mild abdominal tenderness. His labs are a hemoglobin of 7.8, an MCV of 72, a low ferritin level, a normal reticulocyte count, occult blood and stool that was positive, and a colonoscopy that revealed a bleeding colonic polyp. Mr. B has a history of NSAID use for osteoarthritis, and he lives alone and has had poor dietary intake recently. So, the most likely diagnosis for this patient would be iron deficiency anemia, which is a microcytic hypochromatic anemia, which means that our red blood cells are small and they have reduced hemoglobin. This is the most common nutritional disorder worldwide, and it occurs when iron stores are depleted, which reduces hemoglobin synthesis. The cause can be dietary deficiency, impaired absorption, increased requirement, chronic blood loss, or chronic diarrhea. So the first thing that we can address is the anatomy of the GI tract and its role in iron absorption. So our GI tract has a small and large intestine. In our small intestine, we have our duodenum, our jejunum, and our ileum. Iron is absorbed in our duodenum, and it is also recyclable. So iron is regulated in our body not necessarily by excretion, but rather absorption, and we'll get to more on that later. Iron distribution in the body is as follows. 67% of iron is bound to heme and red blood cells. 5 to 10% of iron is bound to heme-containing myoglobin and muscle cells. 30% is stored in mononuclear phagocytes and hepatic parenchymal cells. And 3% is lost in urine, sweat, bile, sloughed epithelial cells, and menstruation in women. And our hepatocytes also play a large role in iron absorption. So, hepatocytes sense circulating iron and use transferrin, which carries and transports iron. But our hepatocytes also make hepcidin, which is regulated by levels of iron in the body, rate of erythropoiesis, and oxygen saturation. So when our ferroportin, that is used to absorb and help transport iron, when the hepcidin and the hepatocytes are starting to recognize high levels of iron or ferritin in the body, the hepatocytes will send hepcidin to inhibit this ferroportin, which stops absorption of iron. So, the physiology of erythropoiesis and iron metabolism is as follows. Erythropoiesis is our red blood cell production in bone marrow. We need 25 milligrams of iron for daily erythropoiesis. So when we have something like a chronic bleed, our body can continue erythropoiesis to compensate for this bleed as long as we have iron storages. But once we have a long enough bleed that depletes our iron storages, our body cannot keep up and we have depleted red blood cells as well. This is different from our anemia of chronic disease because our anemia of chronic disease causes inflammation, which is iron absorption with ferroportin that is stopped. So, the next thing that we can look at for this patient is the lab findings. When we have a lab value of hemoglobin that is 7 to 8, that is when our symptoms of anemia start. So this patient had a hemoglobin of 7.8, so our non-specific anemia symptoms, such as the fatigue, dizziness, and shortness of breath, and the pale conjunctiva, all contribute to our non-specific early symptoms. We also have an occult blood and stool that is positive, and a colonoscopy that showed a bleeding colonic polyp. So both of these show that we have some kind of chronic blood loss in the patient's body, which directly relates to our iron deficiency anemia. We also have an MCV test, which MCV looks at the size of red blood cells. And in men, this level should be 80 to 100, and the patient has a level of 72, which is consistent with our microscopic anemia. We also got a ferritin level on this patient, which was reading low. Ferritin is a protein that stores iron in cells. So when we draw a ferritin level, we're looking at how much iron is stored in the body. So a low ferritin level means low levels of iron stored in the body. We can differentiate this from anemia of chronic disease because anemia of chronic disease shows decreased erythropoiesis from impaired iron utilization. So ferritin and MCV levels usually are normal, but our reticulocyte count is what is decreased in this, which is opposite of our presenting iron deficiency anemia. So the treatment that we would consider for this patient is eliminating the source of blood loss. So we need to get rid of that bleeding colonic polyp. We also want this patient to start some oral iron replacement and increase his dietary iron. However, we have to keep in mind that this patient is a 78-year-old male who lives alone, so he may not have the financial needs for getting meat that is rich in iron, and he may also need help preparing his meals and knowing what to buy that is rich in iron. So suggestions that we can give him, of course, are red meat and poultry, but we can also suggest legumes and leafy greens. And he should also have an increase of vitamin C because vitamin C helps absorb iron in the body. So these would be citrus fruits and maybe tomatoes. The patient also takes NSAIDs, which can cause chronic GI bleeds, so we would suggest that this patient switch to aspirin.